My name is John Harrington, and I'm the founder and Chief Mission Officer of Advanced Practice Strategies. I'm joined today by Laura Sparkman, who's the VP of Clinical Effectiveness, and our guest speaker today is Kelly Rudis, who I'm going to allow Laura Sparkman to make a full introduction and introduce you to Kelly, who's going to share her story, her journey with the power of data and patient safety and the use of our program, what we call GNOSIS. I wanted to start us off with a story of impact, because at the end of the day, that's what this is all about. This is a story of an organization and how they used a program, our program, to standardize the education, to create a shared mental model, a common vision of care, a common nomenclature, to improve coordination and teamwork. And they were able to see the direct results of that improved coordination and teamwork in three specific cases of impact. And in this case, the story we're telling is around the obstetrical hemorrhage or postpartum hemorrhage emergency. Our partner shared with us that she was proud of her team and the way they approached this, and they've been able to attribute three events where they were able to prevent a full abdominal hysterectomy in 3 of their patients. And there's a direct correlation and attribution to that teamwork and coordination of training. So if we stop for a minute and we use medical terms to speak to that, saved uteri, and it's something that I'm measuring, but it's really more than that. It's actually providing that patient, that young mother, with an opportunity to have additional children in the face of an emergency. It was the coordination of care and the way that team mobilized around the emergency that had that direct result and impact. And so this is just one of many, many stories that we hear every day that our partners share. And as I said at the outset, that's what we're all about. That's our only focus, and our only mission here at APS is to help organizations just like yours standardize their care, reduce that variation, create high reliability, improve outcomes, and reduce risk. And for those who aren't familiar with GNOSIS, we're in over 400 hospitals around the country. Over 50,000 assessments have been completed to date, and we're going to talk a lot about what that data tells us. Imagine the exciting benchmarking opportunities that falls out of that rich database. It allows us to see how my team is comparing and concording with other experts from around the country. I can measure and see where my team's needs are. It instructs other decisions in the hospital, what I might do in instructor-led training or in simulation training, and so it's been very exciting for us on this journey. What makes the data so unique for us is that we're able to, for the first time, have a snapshot into the competency on an individual level, but also on my team. I can look at my team dynamic, and the first thing that we can share with you is that there is great variation in care, something that we always know, but each organization is on their own journey towards that standardization and high reliability. That data then drives that individualized learning. So the model today is we have one-size-fits-all training, and it's quite frankly frustrating for those high-end trainers who are taking away from their home life, you're taking away from their practice to send them through training that they're already competent in. And so if we can individualize and prioritize the training, we can dramatically increase engagement, and we've been able to see that successfully happen over and over and over again today. And lastly, this snapshot on the far right, you can see the data on risk. We're really focused on those high-risk areas where organizations are doubling down their efforts. So today's story is coming from one of our clients. Kelly's going to share her own experience, her own passion for helping her organization manage risk in perinatal safety. And to lead that dialogue, I'm proud to introduce Laura Sparkman, who's our Director of Clinical Effectiveness, who's going to introduce Kelly. They've had a great opportunity to work together.
Thank you, John, and good afternoon, everybody. So it's very, very exciting to kind of watch the ongoing journey towards patient safety. The University of Maryland is one great example. So Kelly, first of all, we want to tell you thank you for taking the opportunity to be with us today and share kind of your story so far. We've been working with the University of Maryland for nearly 2 years now, but Kelly Rudis is the Obstetrics Patient Safety Officer at University of Maryland Medical System. She's the liaison between the Office of Risk Management and perinatal providers, nurses, and clinical leadership to advance a culture of patient safety. She has been a certified nurse midwife working clinically since 1999 and has been in this current role for over 2 years. She academically, her background is a nursing degree from Georgetown University and midwifery from Frontier Nursing University in Kentucky, and a master's in public health from Johns Hopkins.
Thank you, Laura and John. It is my pleasure to be here today and share our journey. So today, the objectives will be to describe how education increases patient safety. We're going to review how GNOSIS assisted with this education in our system, and also we'll be explaining how the data results from GNOSIS allow us to zero in on areas where clinicians may need help, both individually and as a group. Let me tell you a little bit about my organization. We are a system of over a dozen hospitals, and my office, the Office of Risk Management, it's called MMCIP, Maryland Medicine Comprehensive Insurance Program. So within the Office of Risk Management, we do clinical risk management, loss prevention, risk mitigation, and risk education. We also handle claims and litigation, professional liability insurance, property casualty programs. So this is the general overview of what my office does. Our mission is to have a positive impact on the quality of services in healthcare, enhance patient safety, and protect the financial assets of our clients. In doing all of these, we're doing the right thing, but that's a kind of our unofficial motto is do the right thing, and we are going to achieve all of these goals in our mission. Where I came into this, I've been working with MMCIP for over 2 years, and our OB patient safety program has been around since 2009. That was inspired by several papers that came out around that time period that really showed the cornerstones of a successful OB patient safety program. Included in that is education, which is really the foundation of quality and safety. And we value that because, it decreases variation in practice, and we want people coming in with the highest quality of education and standardizing that as much as we can, and to have them prepared for all kinds of clinical situations. And part of that education in obstetrics in particular is effective fetal heart monitoring. It is one of the most widely used clinical tools we use. So in our safety program, we have simulation, emergency drills, we standardize guidelines, we do team training such as team steps, and GNOSIS has an SBAR piece that works really well with that because it's a concept we're already familiar with, so it really reinforces that. And then also in our OB safety program, my role as OB patient safety officer is to coordinate these safety initiatives, to promote a culture of safety. I facilitate communication with interdisciplinary team members through various committees and really just in the day-to-day on the unit at the medical center. Collaborate with leaders and staff to achieve these goals. We have a system-wide OB patient safety committee that includes our 6 hospitals in the system that have perinatal services, and we have leaders from each of those institutions, including physician leaders, nursing leaders, nurse midwives. We have an obstetrical anesthesiologist on the committee, as well as neonatal services are represented, and risk management. Our CEO is on the committee, as well as our VP of claims litigation and risk management and a risk manager. So this is a real partnership between the clinical services and risk management and safety. And then also I'm engaged with the staff and have a presence day to day with them as this liaison. So with the medical system, as I said, we have 6 hospitals. The deliveries in those 6 hospitals range from 800 to over 2,100 live births per year. We have settings that range from our urban academic medical center here in Baltimore to several rural community hospitals. And the people that participated in GNOSIS were RNs, and we really looked at every person who uses EFM in any way we wanted to do GNOSIS. So that included labor and delivery nurses, antepartum nurses, so if they were doing NSTs or had antepartum patients who might need to be put on the monitor for contractions. Anyone using it, we wanted them to have the knowledge and decision making to use it in the best way. That includes outpatient in the perinatal center, high-risk patients who come in who are monitored on an outpatient basis. And then among the perinatal providers, we also required every physician who provides obstetrical service, the OBs, the MFMs, family medicine physicians, and also the certified nurse midwives. We asked ourselves why EFM education, and also looking at the alternatives, how we chose APS, and I'll be going through the details of that. Our first question is, what is evidence-based, and why should we use education for fetal monitoring? First is, we see that timely identification and intervention can minimize the risk of poor outcomes for the fetus when there is a non-reassuring fetal heart rate. And also, there's a reduction in actual and potential liability cases and a decrease in the total dollar amount incurred for obstetrics-related professional liability claims. And this is something Laura actually worked on, who's moderating our webinar today. This is something she saw across her organization, so it was really important to see that. We also looked at, in our OB safety program, were several papers that really guided us, and these came out mostly between 2006, 2009, that looked at comprehensive OB safety programs and what those elements were, as I showed you on a previous slide. And at that time in 2009, that there was not something like the GNOSIS platform. However, you'll see on the fourth arrow in, fetal monitoring certification and education was a piece of that. You can see how their adverse outcomes decreased. What they looked at in this study was kind of a composite score of their adverse outcome index, which was the highest morbidity and mortality grouped together and weighted relative to their significance. So this is really a model program for us that came out of Yale that we modeled ours after. We knew that fetal monitoring education would be a piece of that. When I came on board 2 years ago, one of my tasks was, how are we going to get this education and what would be the best education for our system? So I explored every alternative. I researched every possible program out there. You'll see in the upper left various programs that were either a certification or credentialing program, education, competency, and self-assessment. So I think there were probably 7 to 9 programs. And what I came up with, and this is what I shared with both the risk management office and clinical leaders. And I really compared each one, what type of program was, who it was intended for, the features of those programs, the cost, continuing education credits, the time it took, noted who the contact people are, and special considerations. And in presenting this to the leaders in my organization, we really decided that APS was the one for us because it really came through as the best in really all of these areas. And you hear a lot from John in the beginning on what's unique about GNOSIS for OB, but I'll just highlight the things we really like. The standout is it's not just education and assessing knowledge, but it also assesses decision making. That really stood out. Also, as John alluded to, we know clinicians are very busy, whether you're a nurse on your feet through the entire shift and spending extra time for education or a resident on call. You want something that's convenient. And really, we like that it could be people's choice whether you do this online in your downtime, at work, at home, very customized to the individual. And ultimately, a traditional classroom setting would be sitting in a class for 8 hours. This really turns out to be 4 hours on average, which is really a time saver and a cost saver, not to take away too many hours for education, but ultimately coming up with the same result. We like that they have a personal proficiency module after you go through the assessment Basically, the better you do on your assessment, the less you have to do. For physicians, they say, I know this, I do this every day, why do I need to do this? And it's great because really the better you do, the less time you spend on it. So that was very attractive to us. So it really optimizes your time. And then really, and I take this from my own clinical practice, working in various hospitals. There's a wide variation depending on how long you've been practicing, knowing the NICHD language, using it and interpreting really gets everyone on the same page with that. And it's also not necessarily one size fits all. In my own experience as a nurse midwife, I had to do an A1 class that really did not quite fit my area. But what GNOSIS does is there's a nursing piece that really directs questions that are more nursing oriented as far as knowledge and judgment. And then the provider piece has questions more relative to their decision making. So that was another really nice part of it. There were some other considerations. I first heard about this actually through, in the same role as me at another major medical center in Baltimore. It's always good to have that personal recommendation. And we also like that it has other possibilities. Like I said, SBAR is part of that, and also the shoulder dystocia, obstetric hemorrhage, and now hypertensive disorders. So we like that there were opportunities to expand education with the same platform. Once we decided that APS was the best for us and the most bang for the buck, as with any product, you have a sales rep. And personal experience, I really enjoyed the accessibility of our rep. Really, any questions or concerns I had very quickly got back to me. Even when my clinicians were doing the demo, and I strongly advise when you're looking at a program like this, don't make the decision singularly, really let the clinicians see it. So in our 6 hospitals, as we rolled out each one, I had leaders, and by the way, it doesn't have to be a formal leader. Sometimes it is maybe not a nurse manager, but maybe someone who is a charge nurse regularly who does education, but it might not be a formal role as a nurse educator, but someone really who's very passionate about education and really is that go-to person that people will listen to. So I wanted them to all do the demo and give me feedback, and really people on the ground own this and say, we like this, we buy into this. Then that helps me coordinate things much better. The example I was going to give was even when we were doing the demo, there was something that wasn't correct in it. And so Steve, my rep, I said, I noticed this, my team is not going to like this. I didn't like the language in one of the questions. He said, oh, thanks for letting me know. And it was fixed in an hour, and I was shocked that the response was that fast. And that's been my experience the whole time when I've had providers say, like, one of those questions, I think, should say this. So they really want to hear everything to always improve this product. And then also in the planning, we touch base with client services. That kind of bridges into the next phase of implementation. Jolynn is our client services person for that. At this point also, I started talking to the different hospitals to identify who those peer mentors would be. And really, it's just a handful of people. Usually on our teams, we had 2 or 3 nurses. In one hospital, nurse midwife, peer mentor, our family medicine peer mentor, and very important to have an obstetrician peer mentor. And that's really where we saw our greatest engagement with physicians, is when you have that physician champion. And then also kind of that point person at each place who's going to be communicating the plans. So for implementation, we had a real partnership. As I said, Jolynn was ours, and this being something very new for me, implementing this type of education, it was such an excellent experience, and it still is. We decided together who we needed to contact, and really keeping me on track, I gotta say. In implementation, we've set the timeline, and again, that is really up to the team at the clinical level. What works best for your group? Maybe you'll do your training and say, you know what, we just have too much going on. We are already doing electronic medical record rollout or another education initiative, and they might say, we want to hold off for a couple months, let's start it then, but we're going to get the word out, this is coming. So it's totally individualized to the hospital, how they want to set their own timeline of when to do their intro course, when to do the assessment, when to do the SBAR, and ultimately when to finish their learning paths. As with any education or initiative that you're trying to roll out, it's nice to do incentives. Everyone kind of visually likes to see how far they're going, and we would give updates on that. And the utilization reports are really helpful. The leaders can look online who's done it, who hasn't. That's another thing, letting me know the incremental progress, things like that have been very helpful. So then, after our groups implemented this, then we planned a time to give the results. This is where we did the data analysis. So I'll take you through these examples. This one looks at the nurses' assessments. What you'll see on this, the orange square is your particular hospital. All the little green dots on there are the hospitals all across the country with nurses who have done GNOSIS. They're comparing nurses to other nurses. And then you'll see on the horizontal line is the APS average for knowledge, and then on the vertical line, the APS average for judgment. So you can see where nurses in your organization fell relative to the other hospitals. So it's kind of a benchmarking. Then you get to take a deeper look at this data. After you look at your group relative to nurses across the country who have also done the assessment, you can look at how do the individuals within that group. This one is just an example of providers' assessment scores. In this case, the orange square is your facility. So all the providers in your facility, and then the green dots are each of the individual providers, how they scored. You probably notice on both slides there's a really wide distribution, and that's very typical of a first assessment. Remember, the assessment is after the clinicians do an intro course, and you can decide if you're going to require everyone to do that or if it will be optional. This is a snapshot of how do people do on their assessments before their learning paths. It can also break down, this one shows all the providers, but you can also break it down to residents, nurse midwives, and physicians.
Kelly, before we move on to that one,
Sure.
If we could go back. This is John Harrington. You did a great job earlier speaking to the benefits of judging or measuring, I should say, clinical judgment. And what you can see on this slide is that we were able to do the intersection of knowledge and judgment. And what's been exciting is we have clinicians who are really strong. They might have the knowledge. They might be up to speed on NICHD language and patterns, but yet they need to work on their critical thinking, situational awareness, and judgment capabilities. And one of the benefits of the tool that you were just explaining, the scattergram, is that we're able to see that specifically. And if you look at some of these dots on the far right, those are nurses, those are, or in this case, providers. Those are high achievers. They're really strong on the knowledge, but now we have to work on critical thinking and some of those other skills, shoring that up to put them into that upper right-hand corner. That's the confluence of knowledge and judgment capabilities.
And when we look at something like this, we want to look at the outliers and see how can we move them closer to that intersection and also decrease the variation as well over time.
Yeah, that's great. That's great.
Okay. And then also with your analysis, the leaders can look at how is everyone as a group performing in their percentiles in these different practice areas. So it breaks down knowledge, judgment, and various categories like classifying the tracing, characterize change in a category 2 tracing over time. So you can see where they are strong as a group and where they need work and direct your future education in those areas. And then our next steps that we're looking at are when to reassess, and really we want to do it not too soon but not too late. With an adult learning theory, you plan, study, do, act, and we want to repeat that cycle where we embed this education in our other initiatives. For example, even when we're doing shoulder dystocia simulation, we're going to make sure We also have fetal monitor there where someone is reading, interpreting the tracing, making decisions. In team steps training, we're also using concepts, of course, SBAR, but also using that knowledge and judgment of fetal monitoring. And also just creating transparency with this, really talking about it, saying, you know, that there was a lot of fear, people thinking of this as a test. We're really there to reinforce this is not a test, this is not pass fail, but this is really important for your own education to help you feel that you're getting the very best knowledge and preparation to do your very best clinically. And then, you know, as an organization want to look at is, how is this making a difference? As John started off saying, where is the impact? And we need to look at that through data in both the process measures, which you get through APS's data, also looking at clinical outcomes, and then our claims and litigation data over time. And this is how we're going to do it. And I care about it.
Excellent point. That's great. That's a great point. This is John Harrington again. And you just spoke a moment ago about clinical effectiveness, how you're rolling out this program, this idea of transparency, you know, giving better insight into the team's needs. We do have a question from the audience, and I think it's a little early in your case. It's really talking about clinical outcomes. Of course, that's what we get asked that question unilaterally. We're starting off on our journey to measure clinical effectiveness and competency, and is there a correlation to outcomes? I know it might be early in your case. We've shared some of our experience on that, but we want to speak, if you could speak a moment to that, what you're hoping to charge towards, and maybe we can share some of our stories to answer that question for the audience member. But I'll leave it to you first to just say where you are on your journey towards that.
Mm-hmm. Right. Well, we're still pretty early in our journey. Of the 6 hospitals, we have reviewed the data results with half of them, and so we're really at the point where we're deciding on our plan forward and when to reassess. As far as outcomes, I think we're talking about that, and I've been talking with Laura about this. You know, I imagine the important ones to look at are those that are related to brain injury, and also, you know, probably like APGARs less than 7, or in particular pH is less than 7.0.
Core gases.
Core gases, exactly.
Yeah.
I think all the things that you're hitting on are, you know, right on point. And look at your perinatal dashboard now and kind of firm up your metrics. So if you're going to do an obstetric hemorrhage course, for example, you want to start looking at blood utilization, the number of codes that you're calling, you know, and some organizations call them massive transfusion protocols. We've actually had results from, you know, a client who's going to be working towards a publication on the total reduction of, I want to say by 40% of codes called for obstetric hemorrhage, using the GNOSIS program as part of an overall approach. But this, you know, with EFM, the other things to look at are delays in responding to strips. I mean, you have to combine, with OB patient safety, you have to combine risk and clinical practice. You can't separate them, right? But we always lead with what is the outcome for patient safety first. And Kelly, I know I've heard you say that in your program, but I mean, it's a great conversation, especially, you know, where you are in your journey. And again, it's a great lesson for folks as they're kind of thinking, I'm pretty far down the track with my program right now. What are some elements? What metrics should we be measuring? Because you always want to tie back clinical outcomes to initiatives that you're doing, and you have to remember you can't improve what you don't measure. Right. So that's kind of one of my core tenets around that. But John, any other questions?
Yeah, I was just going to add to that, because there's another question that came up, but it's on that same theme. The recurring theme is, you know, outcomes, and so we've been fortunate that some of our partners are, you know, second stage. They've gone through their second assessment, so we've actually seen the improvement from the first to the second. So there's evidence that the model is actually creating an impact for them from improvement of competency. And most importantly, it's the lowest performers, those in that lowest quartile. And we mean that, again, not in a punitive way. It's just those who need additional support. The good news is that we've been seeing the greatest impact for that lowest quartile. And those are the ones, quite frankly, that might be providing you your highest risk and concern. So the good news is that we're having that impact. Laura, as you were mentioning those outcomes, I was thinking of one of our partners who's working on that brachial plexus injury, specifically looking at that as a proxy and reduction in brachial plexus injury as a direct correlation to the proficiency and the team work in managing the shoulder dystocia emergency. And I know you mentioned a moment ago cord gases. One of our partners is looking at cord gases at over a 2-year period and seeing evidence that there was a dramatic impact in what they attribute to better interpretation, standardized interpretation of electronic fetal monitoring tracings and in early interventions that are having an impact on cord gases that are stabilizing at 7.0 pH. So just to answer those questions, we're working with a number of our partners across the country who are really starting to correlate that there is a direct relationship between high performers and competency and reduced risk. So that's incredibly exciting and validating of the work that we're doing with you, Kelly, and all of our partners around the country.
Absolutely.
Thank you so much for taking the time to join us on this call. Thank you so much, Kelly. That was fantastic. Your experience and insight into this and your passion for this is obvious from the way you speak.
My pleasure.
Thank you. You've been a great partner of ours. And so thanks everyone on the call. Our goal is to start a dialogue, is to share what we've experienced in this space. You can see that we're pretty passionate about this ourselves. So we'd love to continue the conversation with you and maybe find a way that we can partner in the future.